So this is the session on RPM and post-acute monitoring. We're going to switch it up today because that's more fun. One of our presenters had a family emergency and will not be here, but in her stead is the CEO of the company that she works for, and I think he will do just fine. My name is Rebecca Gwilt. Oh, I should also mention there's sign-up sheets up here if anybody is going to claim CME hours for any of the sessions that happen in this room today, the Telehealth 101, and then actually not the telebehavioral health, but this one. If you want to, I guess we can pass it around. Oh, that's me. Here we go. There you go. And do you want, if any of you have been around since the 101, we have those as well. Anyone? Okay. Okay. All right, everyone. So for those of you that missed my introduction earlier, my name is Rebecca Gwilt. I'm a partner at Nixon Law Group. We are a boutique healthcare law practice, and we work with innovation in healthcare. Over the past year and a half, actually since the 2018 physician fee schedule came out in late 2017, we have been working with a lot of telemedicine companies and providers who are interested in remote patient monitoring. So that's what we're going to be talking about today. And then Kirby's going to be talking about what they're doing at Locus Health. And then we'll have some time for you guys to ask us questions. So I wanted to start with sort of what is remote patient monitoring. This is my 6th year at Matrix, and the way we talk about remote patient monitoring was different last year than it had been in years before, and that's because Medicare decided it was really too hard to get Congress to pass a statutory change to allow flexibility in the reimbursement of telemedicine, so they carved out what they're calling remote patient monitoring. We used to call it asynchronous telehealth. Now, for Medicare purposes, it's separate from telemedicine, even though I would say it is the use of telecommunications technology to deliver care. That is different. I was talking with a colleague this morning. That is different at the state level. So some states still chunk remote patient monitoring under the umbrella of telemedicine, just another fun way that the federal government and the states differ in this regard. So what I'm going to be talking about today is mostly the changes that came out of the Medicare physician fee schedule, which is a fee-for-service fee schedule. And I'll talk a little bit about how remote patient monitoring is handled by other payers, but just to set the stage, this is really focused on Medicare fee-for-service. So according to Medicare, telemedicine now and remote patient monitoring are two different things. Telemedicine is live, interactive, audio-video delivered remotely to a patient in a sort of rural area who is at an originating site, yada, yada, yada. Have you guys gone to if you haven't, I would go to any sessions on billing and basic Medicare reimbursement because it's way more complicated than it needs to be and more complicated than sort of the commercial payers make it. But in any case, for Medicare, remote patient monitoring is now the use of a digital technology, in some cases a device, in some cases a software, that you provide to a patient and that patient uses in some way to generate health data that is then sent back to the provider who analyzes it and uses that data to figure out an additional care plan, to find out whether that person needs to come in for a visit, et cetera. Oh yeah, I forgot that I have this cheater thing here. Okay, so the types of RPM technologies currently being used on the market, this is just sort of a small list, but we used to talk about this in terms of peripherals, right? So if you're providing telemedicine, in some cases you could use a peripheral device. So that's your blood pressure cuff, your pulse ox, your heart rate monitor. The new Medicare rules are pretty broad or pretty agnostic to technology, even going as far as not to require a device at all. And so, the sky's the limit, sort of, for what kind of device you want to use as something you're using, as something to collect patient data. So we have a Fitbit or an Apple Watch. I don't see why not. Respiration devices, weight scales, just stepping on a scale every morning and having that sort of Bluetooth enabled, sent back to your doctor. I would argue you could use a pedometer, a simple pedometer. Anything that collects physiological data that you could use to make decisions about a patient's healthcare. The big benefit, as I mentioned, Medicare sort of stopped calling this telemedicine. The big benefit here is statutorily, meaning written in the underlying law, telemedicine is quite limited and includes, and requires a patient to live in a rural or underserved area, for that patient to be at a specific originating site, a clinic or an FQHC, or a hospital, sort of a different hospital than the provider is located. And there was no direct-to-consumer option, no direct-to-home option for telemedicine. So the big benefit of this recharacterization of remote patient monitoring is that there is no geographic boundary, there's no originating site restriction, and you can do it direct to patient. So right now, who's paying for RPM? And this tends to change year over year. This is a graphic that I've used for a couple of years, and I keep adding to. But right now, there are a lot of physician practices that are doing remote patient monitoring that are not getting reimbursed for it on a fee-for-service basis. A lot of times, those are physician practices who are either concierge or are involved in some sort of other a payment scheme. So a shared savings scheme, a bundled payment scheme, some sort of capitation, some sort of, direct relationship with an employer, something like that. Hospitals and health systems have been doing this for a while. There's very classic remote patient monitoring, like cardiac monitors, that have been around for a long time. That's not really what the new RPM codes are about. But we know that Medicare Advantage have been paying for telemonitoring for a while for a very limited set of devices. Commercial payers are paying for it. The commercial payers generally tend to watch what Medicare is doing, but there are a lot of them, especially the ones that have started commercial ACOs and that are doing, that are piloting an innovation, that are paying for this kind of thing on a per patient basis. Now that there are Medicare codes, they're now going to be paying for it reimbursing under a fee-for-service schema. The extent to which they use the same parameters of Medicare, we will find out. But commercial payers, population health vendors are paying for this, especially those population health vendors that have taken on risk on behalf of their customer healthcare institutions. Again, now Medicare is paying for it. Medicaid is paying for it, especially in states that have moved, that have made the most progress toward managed care. Those managed care providers are getting a lot of flexibility through Medicaid to be able to provide remote patient monitoring, especially for the dual eligible population. MSOs and physician practice management companies, ACOs, electronic health records vendors, and even medical malpractice carriers are starting to pay for this kind of thing. So what are they buying? What are we buying when we pay someone to remotely monitor their patients? One is the early intervention. So there's still a lot of focus on reducing hospital readmissions, or at least avoiding the penalties for hospital readmissions. And we know that if we can intervene with a patient early on, we can prevent them from escalating to a high acuity environment. So, for instance, there's a lot of new innovation now in providing remote patient monitoring to skilled nursing facilities and other post-acute providers to keep them from cycling out. To improve patient satisfaction. So there's measured patient satisfaction that goes into your MIPS score in the aftermath of MACRA. Improving patient satisfaction, I'm sure those of you in the provider community know, has a lot to do with reduction in malpractice claims. And also marketing. This is a real opportunity for a lot of folks to be differentiators in their market if they can offer this kind of sort of innovation in healthcare. Managing care quality and costs. So being able to target intervention across episodes of care, better manage the chronically ill. I will get into this later, but the RPM codes now are not supplanting the chronic care management codes. In fact, Medicare does suppose that there will be people using both CCM and RPM codes at the same time. Building revenue streams. Fee-for-service reimbursement for things that in some cases providers are already doing has been has been great news for providers, and I would argue even better news for technology companies that are trying their best to sell their technology into these providers. Now they can say, hey, there's a fee-for-service code that you can take advantage of to help pay for our technology. And to increase access to care. This will be a refrain for a lot of this conference. One of the great benefits of telemedicine is to be able to provide care to people who are far away from the care they need, right? The whole idea that your zip code should not determine whether you live and die of some diagnosis, and remote patient monitoring is one way to do that. Wow, I got chills. I always get chills when I think about that. So here's the trend. So the way that these codes came about, this super secret insider info, is that the American Medical Association's Digital Medicine Payment Advisory Group, or the DMPAG, was tasked with coming up with new codes, a way to innovate in this direction. There was a lot of stakeholder input, but the DMPAG actually did come up with the concept of unbundling one of the codes that came out in unbundling the code that came out in 2018, which I'll talk about. And they continue to do so, right? So the difference between what happened in 2018 and what happened in 2019 in terms of the physician fee schedule shows us that there's a trend toward the acknowledgement that remote patient monitoring and being able to intervene at the right moment for a patient is a way to improve health outcomes and decrease costs, which of course the federal government, as one of the biggest payers of healthcare, cares about a lot. So I'm going to pause there and see if anybody has any questions so far before I get into the heavy text slides. Oh, and you can also, if you go to our session in the app, you can enter, there's a thing that says add a question, there you go, and you could submit a question for me. I'm going to circle back on the questions at the end, but you can submit questions and I will make sure I respond. So is there anyone who wanted to raise their hand really quickly? Great, okay. I'm doing a really good job. So the great unbundling. In 2002, the code ZPT code 99091 was created to document the work of physicians who are reviewing remote patient monitoring output to make decisions about their patients' care. Since 2002, 99091 has been bundled into other E&M codes. So that means basically you couldn't charge for 99091 and for the E&M visit. In 2018, in the 2018 Medicare physician schedule, Medicare physician fee schedule, they unbundled 99091, meaning it is a separate billable code that physicians can bill for time spent collecting and reviewing physiological data. And again, it does not supplant the existing codes for transitional care management, for chronic care management, for behavioral health integration. This is a whole separate can of worms. You can't bill it for the same time that you spend on both, but you can bill it concurrently. So here's the detail on CPT code 99091. It is the collection and interpretation of physiologic data digitally stored and or transmitted by the patient and or the caregiver to the physician or other qualified healthcare professional, and that requires a minimum 30 minutes of time. In order to bill 99091, you have to first have a face-to-face visit to establish the patient relationship. You have to have advanced beneficiary consent to provide them remote patient monitoring under 99091. And you have to spend a total over the course of 1 month of 30 minutes reviewing and collecting and interpreting that data. And then if you're doing that, you can bill it month over month for each patient that you remotely monitor. The important piece of this, and the one that caused the most heartburn, especially, I don't know if Bonnie Britton's in the room, but she was my presenter last year on 99091. But the thing that caused the most heartburn was they were requiring a physician or other qualified healthcare practitioner to spend the time to remotely monitor the information. And first of all, looking at the reimbursement rate of it, it was never going to be a great incentive for a physician or other qualified healthcare practitioner to provide those services. Right now, if you look at what's happening in CCM, it's generally clinical staff and not physicians that have to spend the time doing this. And so there was a little bit of uptake on 99091. It signaled that AMA and CMS were ready to talk about remote patient monitoring and how they could encourage it and incentivize it in the market. But there were some major problems. First was the physician time, of course. The second was the technology costs. There's nothing in 99091 to help you pay for the technology that it would take to actually be able to collect this data, right? So there was no device code, no equipment code. It was just an E&M code. The third problem was documenting compliance. So there was no number one, they never put out guidance, which was very bizarre because they did right after CCM came out. And they basically said they weren't going to put out guidance on 99091. They wanted to see how people would use it, if they would abuse it, the kinds of questions that came up once it came out. And in any case, there was no detail around how you documented how you complied with the 30-minute timer, right? So most companies said, okay, well, this doctor has 10 patients that she would like to remotely monitor. She has to check in on each patient 2.5 minutes per working day, and is there a timer, or could she look at all of those patients for 2 minutes a day and bill all of them for RPM? There was no, there's sort of your gut that says that's probably not what CMS had in mind, but there's no guidance around it. So documenting compliance was a big problem, and then defining physiological data. What did that mean? The examples they gave were ECG, blood pressure, and glucose monitoring. But it was EG. It wasn't limited to ECG, blood pressure, and glucose monitoring. And in my conversations with folks that were involved in sort of structuring this language, they said, well, they did this on purpose. They were technology agnostic. They were physiologic data agnostic. There was no definition, and that was sort of left open. So all of that served to prevent a lot of uptake of this code and a lot of feedback. And so what we have now that came out for the 2019 physician fee schedule is three new codes that include the initial setup and patient education for the remote patient monitoring device, a reimbursement for the device itself, and another code that was very similar to 99091 called 99457 that solved a bunch of the problems that people had with 99091. So I'll just say, in general, the information collection device does need to be a medical device pursuant to the FDA definition of medical device. That does not mean that the device that is used has to be FDA approved. So FDA defines what a medical device is, but there are several classes of medical device, and only some of those classes need to be FDA approved, need to go through the process to get FDA approval. If you have any questions about that, you can come and ask me afterwards. In general, the service must be ordered by a physician or other qualified healthcare professional. As far as we have been able to gather, what qualified healthcare professional means is someone who can bill directly to Medicare. There are several definitions all over the code, and it has been a year in the making trying to find people who will clarify this for us, but that's what we know so far. Also, even though they call it chronic care RPM, it is not limited in the way chronic care management is to 2 or more chronic conditions. The person doesn't have to have any chronic conditions. So here's the first code, 99453. This is your code for the setup and patient education. So if you imagine, I'm Dr. X, and Gwilt, we'll call me Dr. Gwilt in another life. I'm Dr. Gwilt, and I've got patient Caitlin. And Caitlin is having some trouble breathing. She's got COPD. And I'm managing her with chronic care management, and I've got people calling her and spending time, but I'd really like more assurance about what's going on. So I have this company that approached me, and they've got a device that monitors respiration for Caitlin. And she can just wear it right on her clothes, and it'll sort of pick up her respiration rates and send it to me in real time. So the first thing I'm going to do is, I've already had a meeting with Caitlin. We've already had our face-to-face. I'm going to bring her in, and I'm going to say, okay, we're going to remotely monitor you. Here's the device. Here's how you use it. here's what I'm going to need you to do. This is what this means. You get your informed consent, and you can bill that code 99453. It can only be reported once per episode of care, also a very interesting distinction. An episode of care is what you make it. So generally you need to set out some treatment goals, and the point at which you attain those treatment goals is the end of your episode of care. I'm sure there will be lots of fights over that. But in any case, reported once per episode of care, the monitoring must last at least 16 days, and then it can be used in conjunction with 99091 and 99457, which we'll get to in a bit. So Caitlin's going to go home and use this device that this company is selling to me, and I don't have to pay for this device because I get $69 each 30 days to reimburse me for the cost of that device. So 454 is your reimbursement for the device that you're using. Again, you don't have to have a device, but if you want to bill 453 or 454, you do. You could use 99457, which we're going to get to, without a device, but for the purposes of this hypothetical, this is the device. So I'm going to get $69 month over month for the device that's going to send me back transmissions about Caitlin's respiration. And again, that the monitoring must last at least 16 days. And one item which we'll come back to later, sort of the unanswered questions portion of the presentation, is the language says daily recordings or programmed alert transmission. We don't have any information about what that actually means yet, not concrete, though in the rule, CMS did say that they were going to come out with more guidance on this. In any case, my opinion is if you have a remote monitoring device and it's sending information in real time, or you're saying, I want you to weigh yourself every morning, right? Stand on the scale, and the device sends that to you every day, you're meeting that daily transmission requirement. All right, and here's 99457. There's been a lot of questions we've gotten over the past year about this particular code. One, it does not replace 99091, but it is very, very similar. So 99457 is the code for the time that it takes to review the data that comes in on your patient. It requires 20 minutes per month rather than 30, and it can be, and those treatment services can be provided by clinical staff, which again, we didn't have with 99091. Similar to 99091, you've got to have a face-to-face visit first, you've got to have consent, and it can only be billed once per calendar month, and I think it was a 30-day period for 99091, right, which caused confusion as well. Monitoring will last 16 days, and you can't monitor, or you can't bill it within 30 days of billing 99091. So, just to give you sort of a comparison, like I said, 457 really solves a lot of the problems that people had with 99091. You can still bill 99091. My guess is not many people will now that 99457 is in place. A couple of the key differences is 457 is only 20 minutes a month, though the reimbursement is somewhat lower. It's based on a calendar month rather than a 30-day period, and it allows time to be billed by clinical staff rather than requiring a physician or a qualified healthcare practitioner. Okay, so one of the issues with 99457 that came out is that it said that the services could not be billed incident to physician services. And that was problematic because clinical staff can't bill directly, so the only way you could mobilize clinical staff would be to have them bill incident to a physician or other qualified healthcare practitioner. So that was very confusing for a couple of our clients. We submitted some comments to the government, and really based on just our feedback alone and no one else's, they did this technical correction. That's a lie, that's a lie, I'm lying about that. I'm sure there were many people, but it was very confusing. So I think a bunch of us, right, wrote to them and said, hey, this doesn't make sense to us. And they came out with this technical correction. So now it says they can bill incident to a physician, which is great because you get the benefit of this clinical staff change. However, in order to bill incident to, you generally have to have direct supervision. So this means that the business model whereby the people doing the remote patient monitoring can sit in a call center somewhere outside of the physician office, or can sit at a separate place from the billing practitioner, goes out the window. Because that requires general supervision, right? Where the physician is available to answer questions, but is not available in the office where the remote patient monitoring is happening. So that was quite a disappointment. That was one of the things we tried to get them to change. I'm hoping that in the 2020 physician fee schedule that will change. But for right now, 99457 cannot be billed unless by clinical, based on services provided by clinical staff, unless the billing practitioner is present in the office. So there's some remaining questions from the chronic care RPM rules that came out. One of them is about this technology language about whether there is a requirement for daily transmissions. It's sort of a weird thing to say, and we expect that there will be guidance that comes out shortly. They have indicated that specifically this year, probably because all of us said, hey, providers aren't going to do this if they don't explain what the rules are, because you could come and claw it back from them. You've got to give us guidance on this. So they're going to come out and say that. What types of technology can be used? We would like some clarification on that. We're still waiting for clarification on physiological data, what that means. And then whether 453 requires an in-person meeting versus being able to do that remotely. Just a reminder about Medicare fee-for-service copays. All of these services are going to require 20% copay for beneficiaries, which is why that advanced beneficiary consent is required. So there aren't really exceptions to that now. There have been in the past, right? We are advocating on behalf of our clients that there is an exception made here. If the federal government really is doubling down on the fact that remote patient monitoring is going to save them money in the long run and keep people healthy, well, why in the hell are you going to? Why are you going to require 20% copay? Right? The point is it's paying for itself. So that sort of remains to be seen. Private payers in the commercial space, again, most of this presentation is Medicare-based, but private payers in the commercial space can come up with whatever they want to come up with in terms of copays and deductibles. And just really quickly, there are other non-Medicare fee-for-service programs that are paying for this. Again, the commercials in Virginia, we have talked to a lot of them. They are reimbursing for remote patient monitoring. Telemedicine parity laws, we're waiting for states to say, hey, remote patient monitoring is telemedicine, right? So from a state perspective, it's a great idea for that to be the case. The federal government had to split it for legal reasons, but states don't have to split it. So in states that have telemedicine parity, we're looking for them to go, remote patient monitoring is slotted up under here, and Virginia has. There's always been Medicare Advantage telemonitoring. They have some leeway to provide those services, and many of the technology companies that my firm serves are approaching directly Medicare Advantage plans because they're able to be a little bit more creative with their Medicare population. And the last is the 2019 Home Health Prospective Payment System rule. Home health is paid. Is there anybody from home health in the room? Okay, so maybe you don't care, but home health is paid on a prospective payment system, much like hospitals. And what the latest rule said is you can add telemedicine services to your cost report. That doesn't really mean anything now because they don't get reimbursed extra for it. But the idea is if a bunch of home health agencies start reporting this on their cost report, then maybe the federal government will figure out that that's something that's a desired service and then start paying extra for it. This is the last slide, and then I will turn it over to Kirby. But I wanted to point out that outside of the fee-for-service reimbursement for remote patient monitoring technology, there are benefits to using RPM in your practice. So I'm sure you've heard MACRA a million times by now, but the Medicare Improvement Payment System, I think, MIPS, it's been a while. does take into account new clinical practice improvement activities when it determines what your MIPS score is. And that score is going to determine ultimately, for Medicare, going to determine ultimately whether you get a penalty or you get a bonus on your Medicare reimbursement year over year. And engaging patients and families using patient-generated health data, which is the health data that comes from remote patient monitoring, to guide improvement in the system of care is a high-weighted activity. So you can really bump up your MIPS score and in some cases get a pretty significant bonus if you can demonstrate that you're using RPM for your patients. There's a couple of other ones, engagement of patients through improvements in the patient portal. That can be used. It's not really remote patient monitoring, but it's another sort of patient engagement kind of thing. And then integration of patient coaching practices between visits. You could cover some of these and just through the use of remote patient monitoring really increase your MIPS score, which I think is just an added benefit here. So I'm going to take a breath. I know that was a lot. I'll be here for questions at the end, but I'm going to turn it over to Kirby Farrell from Locus Health, and thank you so much for your time.
So my pleasure to be here, and I first want to start off by just saying that personally, I hate the word remote monitoring. Like, I get it that we have to call it something, but in my line, and really our view is that you monitor power grids, you monitor traffic flows, you care for people, and so this is really all about creating technology that enables you to really care for people. And what we're talking about is a fundamental transfer of the burden of responsibility from the patient to the clinical care team that is supporting them. And especially in today's world, you're really talking about, especially in a post-acute care setting where you have uninformed patients about what they should be doing, and the responsibility is on them. So really, when we're looking at this stuff, what we're thinking about is when that patient gets up in the morning, or we do a lot with children's hospitals, when the parent gets up in the morning, they're trying to answer 3 or 4 fundamental questions. What do I need to do today? How can I tell how I'm doing? How do I tell if I'm not doing well? And what do I do in that case? How do I communicate with someone? And if you're the care team, you want to know, who should I be paying attention to? What should I know about them? And how do I communicate with either them or members of my care team that's also supporting them? And then lastly, maybe you want to know who has stopped playing, who has stopped engaging on the remote end and is no longer participating. And certainly when you're doing this, engagement is key. You need that care team that's engaged. You need engaged clinical teams, you need engaged patients, and best of all, if you actually have an engaged health system or at least leadership at that health system. Let's see here. So, when we're working with the hospital, or certainly in your systems, obviously you need that clinical champion, you need the executive support, and you need IT support. These are, though, clinical solutions, so you start with that clinical champion, but at some point this all has to be connected through IT, so you need the IT support as well. When you're thinking about this, there's just a wide variety of things to think about. I'm going to see if I go back there. All right. You've got to think about the devices. Who's managing the devices? You've got to think about, by the way, where's that connecting to, that platform, and who's managing that piece of the business? And then you need to think through, by the way, we also need to connect this back into our network and then eventually into the EMR. So it's a comprehensive system. You think about, well, we're putting these devices, or we're putting systems in patients' hands, but someone's got to think through that whole thing. Someone's got to think through how it works. And our experience, by the way, in getting started sometimes is to think small. So rather than trying to boil the ocean, start with a specific patient population. So this is some examples of what a system can look like. So in our case, we happen to use iPads. So we think the iOS platform is secure, private, easy to use. And really what this is all about is, again, you get up in the morning and you want the system it's telling you, what is it that I need to be doing today? What's the data that I need to be tracking? But many times, we talk about devices here, but there's many things you want to know about that patient at home that is not going to be tracked in a device. You want to know how the patient's feeling. You want to know their pain level. If they're kids, if they're babies, maybe you want to know how many diapers they're filling. You want to know how the breastfeeding is going. You want to be able to take a picture and send that not via text that you're not allowed to do, but actually in a secure way. And hopefully you want to do either record a video or do video conferencing, all with that patient remotely. And by the way, again, if something is out of range, if something is going wrong, you want to alert the patient. You want to alert the parent that something is going on at their end. When we're talking about this kind of post-acute care, it's not a tele-ICU in most cases, right? There's not a clinical team that's staring at a dashboard 24/7. If the patients need actually that kind of care, of course, they should still be in the hospital. But once they go home, you want a shared responsibility. So something's out of range, you want to tell the patient, hey, is this really happening? And if they say yes, you want to be telling them exactly what to do. And then obviously you want to educate them as much as possible. So if you can have a platform that's giving all kinds of patient education targeted specifically to that patient population, whether it's written or video or whatever, this is the magic of technology now. You can put that in the patient's hands, explicitly targeted to them, and then you want to be giving the patient, you want to be giving the family feedback loop so they can see how they're doing. A mother can see, is my baby gaining weight? You can see, am I losing weight over time? You want to be able to, in a perfect world, you want your patients seeing the same kind of trends that their physicians are seeing. And then it also be nice if they could take photos or surveys. Again, this is all about, the difference between raw data looking at and be able to see a photo or a recorded video so you can hear someone cough, you can look at the wound. It's a dramatic difference, and in both those cases, of course, you're taking real advantage of that sixth sense that clinicians have after taking care of patients for years. And then surveys, you could put in there, you want to know the seventh day, you can put all sorts of questions in there targeted to them. And then, we often talk about what's going on at the patient side, but there's another side to this equation, right? Who is looking at this data? What kind of data are they looking at? How are they looking at it? So, in our world, what you want is a true mobile platform. So you want the clinicians from their mobile device, whether their phone or iPad or whatever, to be able to see this kind of data in a HIPAA-compliant way so that they can do this. Many times this care is not being delivered to someone sitting at their desk. So you want a clinician to be able to see this kind of information while they're on the move. So we have are they going to run this? Let's see. All right, let's see. Can you guys hit play there? So this is 2 minutes. I don't know if you can hear it.
I am a neonatologist, which in layman terms is a baby doctor.
Hello, sweet girl.
I take care of any child that cannot go home with their parents straight from the hospital after birth. We get patients that come from 4 to 6 hours away. Sometimes the kids are only here for a couple days. Sometimes they're here for months. Parents' number one question to me is, when do they get to go home?
We've had to make 3 trips so far, home and back, and it's been stressful and exhausting.
That's down and back, trying to get sleep and coming right back again.
There's a lot of babies here that are not that sick, and they could be home with their family if we had a way to monitor them outside of the hospital. And that's kind of where the idea came from, to send him home with an iPad, send him home with a scale, and keep doing the things we were doing here, but I can do it while they're at home.
What do we say, 6'6"?
The parents input their data into the Locus Health app, and I can customize every individual iPad to have what information I need about that specific patient. I get how much they take by mouth, what their oxygen saturations are, and that information goes directly into their electronic medical record. So I can look at that information just like I would here.
You have a picture of what having a baby is going to be in your mind. So being able to come home gave us back part of that normal.
I couldn't fathom a better system than what they've developed here. Being in a home environment while still being cared for at the highest possible quality of care.
She seems to do better when I'm holding her instead of holding her neck.
And that's a position that we really want to encourage over time.
Once they get into the home environment, they do so much better than they do in the hospital. At the same time, we have the ability to care for another sick child that may need the neonatal intensive care unit.
We've done this in kids that are receiving chemotherapy. We've done this in kids with cystic fibrosis. We've done this in patients that have received solid organ transplants. We found with all of these other populations, we're achieving the same result.
Now we're gonna burpee, girl.
We're getting them home sooner, and we're caring for them and engaging in ways that we never have before.
What we do here is really important, but if we can be doing it at home, let's find ways to do it at home.
So the doctors tell a better story, obviously, given their description, and that's a good example, by the way, where the clinical teams are completely engaged. And especially, I didn't realize the ruling now was that the care team had to be physically in the same place, which, by the way, is sort of interesting because in a health system, they're not in the same place, but I guess they have to be part of the same organization, is what that says. So I'm not sure what happened to the rest of the presentation. Oh, here we go. So this is just, that was the end of it. At any rate, I really appreciate actually hearing about the nuts and bolts here, but you know, we really are talking about a total transformation of the U.S. healthcare system. It really is happening, and it really is, though, it is about extending the care. It's not about it's not about raw data. It is about clinical teams engaging with the technology, engaging with the patients, and figuring out how to really do this in a home environment. So that's it. Thank you.
Okay, so here we go. What's your reaction? Your reaction to the decision to require direct physician oversight. Well, I'm just the lawyer, but I will tell you my clients were not super pleased. There are several entrants into the RPM market that are currently in the CCM market, and that business model is viable because the chronic care staff that's calling the patient and following up with the patient isn't necessarily on site, right? You can be a separate CCM company and sell to doctors' practices and provide their CCM services, but you don't have to be in their office. That's just not going to be a viable model until this changes. So yeah, I was just the bearer of bad news. What are the hurdles with deciding which data to send to the EHR, and how do you determine the quality of the data? Do you have any thoughts about that?
Yep, great question. It's not actually as big a technical hurdle as people think about. You're really talking about workflow integration, which is where in the EMR this data should go. And then there is the issue of keeping the data that is gathered remotely separate from any data that's gathered in the house, because patient-generated data or data sent from a non-FDA approved is a different kind of data. And then the real magic happens if you can figure out a way to combine those two. But the real hurdle is time and attention from your IT staff. The hurdle is lack of time, but very doable, not just for us, but for, and it's done. I mean, we've done it, other companies have done it. It's a very, it's again, it's not a big technical challenge. It is much more a workflow challenge and focus.
Yeah, and so from a risk management perspective, it's a good question. We don't have a lot of case law so far on sort of how courts will look at the interpretation of poor remote patient monitoring data as it relates to medical malpractice actions. It is important to vet the technology that you are using to make sure that it makes sense for your patient population, and determine which patients really should be going home, right? So UVA is not sending everybody in the neonatal intensive unit home. They're making some sort of evaluation by, I assume, based on some protocols that they have put down on paper, where they say this child meets the risk profile that's okay to send home. You should be thinking about that as well. I also think that very well-crafted consents for patients are quite important, right? Where you say to the patient, hey, just so you know, if you don't weigh yourself every morning, or if you try to cheat this device or what have you, and we get bad data, we can't take care of you, and we can't be responsible for what happens. There's one thing for the technology to break down, and there's one thing for the patient not to comply, and both of those introduce risk. So it should be part of the conversation that you're having with your organization to determine sort of where your risks lie and how to manage it. Do you anticipate big EMR companies such as Cerner and Epic will build their own RPM platforms? What do you think?
I actually don't think so. I think they certainly could. I mean, it's software, they certainly could, but I think that their focus is elsewhere. I think the market is still too small for them to spend the effort on it, and I would never predict what Epic will or will not do. I would think Cerner would probably buy it when they do get into it. But I think that I think that most of us on the other side of that EMR are now all about integrating with the EMR, and it's. I certainly don't think it's something they're going to do in the next 3 to 5 years. So if there's anything in your foreseeable future you're interested in doing, I do not think the EMR companies are doing it.
Yeah, although I do find that a lot of companies are building their software to be able to integrate.
Oh, absolutely.
Yeah.
I mean, I think everyone in this space gets it that life begins and ends in the EMR. So that's a fact, and you need to work with that.
Yeah, although it's interesting because once it ends up in your EMR, you're responsible for it, right? And so I get a lot of questions about, what if the device is sending something every 5 minutes and we only have a time to check it once a week or something like that? Does it mean that we have breached our standard of care by missing something that was, collected by us through remote patient monitoring, that we just couldn't check it every 5 minutes to find out how this went, and I think that's still an open question. I mean, I think courts are going to use common sense initially, but there will be cases where people get in trouble. It sort of leads into your next question, right? Disclaimers. This is not, one, you should have a patient privacy disclaimer. 2, if you're billing for these codes, you have to have a beneficiary consent. to be able to bill them and then charge the patient the copay. And 3, you should be very clear. If it's an emergency, go to the hospital. This is not, this remote patient monitoring is not so that you can stay in your home to the last possible second till you flatline, right? This is to help in your chronic care management. And so being clear with the patient during that education portion should help sort of reduce that risk somewhat. All right, is the 16 days rule straight data monitoring days or per encounter / data collection days? Per encounter. Okay, so I'm gonna ask my colleague Caitlin to correct me if I'm wrong, but the 16 days exists for 99453 to prevent you from, for the same patient, billing that startup and patient setup code constantly, right? So you say, I'm going to remote patient monitor them for 5 days, and I'm going to charge them $21 every 5 days, right? And the same for the device, right? They don't want people gaming the system. They want people actually monitoring people, not just charging the setup codes. That would be my guess.
Yeah, I think so. It's just to make sure, sort of like you said, that there are actually treatment goals that are being met and set, rather than, well, I looked at their weights for 5 days in a row, so I was monitoring them.
Right.
It's like goal setting and making sure it's legitimate.
Right. So some of these are billed per 30 days, and some of these are billed one time only, right? So the 453 for setup, that's every time you set up and you have new patient goals. They don't want you to do that every 5 days because there's not really enough time to reach a patient goal in 5 days. The second one is your device. Yeah, so they don't want you charging for, staggering charging for these devices without actually having them give some data back to you that you can interpret. It's once per calendar month.
For the patient. So it can start on April 1st, but when the patient gets admitted to the setting, it can start for that patient on April 10th. At their time of their entry.
Right. Yeah.
On kind of on a rolling basis, whenever they qualify, they have the criteria that they need to apply.
That's right. Yeah, I mean, if I were a technology company, I would be building in to alert me sort of which day is the day per month that I'm billing for them. But yeah, no, you don't have to, you don't start at the beginning of the month, right? You can start whenever they come in. Yeah. Physiologic data now includes blood glucose monitoring. Could other lab tests be interpreted as physiological data? I don't see why not. Nobody's defined it. My question that I keep asking is, could I give my patient a pedometer that counts their steps per day and call that physiological data? I think I can. It's not complicated. It's very cheap. I don't know what CMS would say about reimbursing me $60-some per month for a pedometer, but there's nothing out there that says I can't. So a lot of this is still sort of Wild West. What we tend to do for our clients is we set up a meeting with somebody at the Connected Health Initiative or at CMS, and we say, hey, here's a hypothetical. What are your thoughts? What I will say is the feedback that I've gotten so far is that CMS does not have an interest in coming after people who acted upon a reasonable interpretation of what the law says. So some of the risk, so whether you want to start billing these without full information is really based on your risk profile. Larger institutions are likely to adopt this later than smaller practices, just because the risk is lower. So I think that's all the questions we have through the thing. I really appreciate your time. Oh, crap.
All right.
Okay, I got it. That's why I'm here. What is LOS? Length of stay, thank you. How will length of stay in post-acute care be affected by the need for 16 days of monitoring?
I'm glad you're the lawyer here answering
Yeah,
those
so
questions.
so I would say is a lot of post-acute care is not fee-for-service. So a skilled nursing facility, not fee-for-service, hospital, not fee-for-service, home health, not fee-for-service. So, so what we're really talking about here is physician services. So I'm not sure how to answer that question.
Well, just move on then.
Okay. Whoever asked it, meet me outside, and I'll. Oh, that sounds terrible. Meet me outside.
By the way, I do think one thing with the billing is it's great movement. I mean, it's great to see that this is coming is here. In most cases, it is not sufficient to by itself get support for a big remote monitoring program. That it's a good movement, but you need more, especially in terms of economic justification, than the fact that you can bill for it.
Right. Yeah. Nobody's going to get rich off of the RPM codes, but again, this is the way the healthcare system is going, right? Paying for outcomes, paying for decreased costs, paying for keeping people out of high acuity situations, and so I think the early adopters are going to find that they're going to be the survivors, moving forward.
I think it's fair to say with some of the stuff too, right there, no one knows.
Yeah.
I mean, bill it.
Yeah.
Right? I mean, with some of these specific.
Yeah, I'll fight with the insurance company.
Right.
Okay, what if a patient is readmitted after completion of the 16-day episode? Then what? Would the patient still be eligible for RPM? Would the patient need a new?
I think you would. I think you would need a new order then if you get discharged. Yep.
Yeah. Well, they leave so they're leaving the.
Be a new episode.
Yeah. Could pressure injury wounds, along with periodic wound imaging, be captured under RPM? So again, I don't see why not, but I would also offer that there's another new code for remote evaluation of transmitted images and video that it also is new as of 2019. So you may want to consider, especially dermatologists and folks that sort of are looking at wound care, that can sort of visually assess things, to check out that new CPT code. It's G2010. It's a G code. G2010. What about chatbots? Is that RPM? I don't
think so.
I don't know what a chatbot is.
I mean, like artificial intelligence and
like the
Yeah.
pop-up, how can I help you on the?
Yeah. I would say not, but.
Yeah, so 99457 requires interactive communication between the clinical staff member or the practitioner and the patient. So if it is something like AI generating responses, I would say no. But if there's a way for the physician or the clinical staff member to be participating in that chat, then potentially yes, it would be part of that.
Could everybody hear her answer? Okay, so that's okay.
The answer is no.
The answer is no. The part of the requirements for 99457 is that there be interaction between the physician and the patient, and AI-generated or chatbot-generated interaction does not count. However, if the physician is involved in the chatbot situation, then yes, that counts as remote patient monitoring. How are folks reporting volume per patient per 30 days per day per hour? Reporting volume. So what's being billed is, so what's being reported is that it's being billed on every 30 days. Depending on the technology you use, it may be collecting a lot of data or not a lot of data. We've got some clients that are just using timers. So they'll collect that this has been 30 days and then they can go ahead and bill it, or that this has been 30 minutes for 99991 or 20 minutes for 99457, and then that allows them to bill it. Now reporting, if that means cost reporting, that's not a fee-for-service kind of thing. That's more for hospitals.
Yeah, I don't know.
Yeah. again, there's a lot of this that is unknown. Part of the game is being able to know who you can ask the question of, and so there are several people at this conference that have sort of those channels to folks in the administration and folks at the payers, and that's sometimes just what we have to do. Are there any more questions, my guys in the back? Yeah, go ahead.
When you talked about the disclaimer saying, in case of emergency, call 911, does it need to be done once the patient onboards this RPM system, or does it need to be done every time the RPM data is loaded?
One time.
Yeah, I can't imagine a scenario
You do it at
every
discharge.
time.
And by the way, typically you'd hopefully tell them something more than dial, well, certainly there are cases where they should just dial 911, but there could be other cases where you want to be a little more specific than 911.
Right, and a lot of these technologies are not being pushed by the patient, right? So the patient really isn't submitting anything. The patient has, in some cases it's software and they're plugging something in and they're saying submit, right? That's, the Locus Health model. And some of these, it's put on a cuff once a day, or weigh yourself in the morning, or, prick your finger whatever that schedule is, and the information goes. It's Bluetooth enabled and it goes through the system. So a good question would be that advanced beneficiary consent, whether you can keep that on file for every episode of, not episode of care, but for every sort of set of treatment goals, periods, I guess. But I think you could craft a consent that's revocable, and then you could just use it until it gets revoked by the patient. Go ahead.
So with compliance, so let's say you have a patient that you're monitoring, and this patient has maybe high blood pressure multiple times, and it was not actually monitored by the clinics. So now when it comes to someone who's responsible for that patient, let's say there's a sewing issue coming up, so who's liable, will be responsible for not monitoring and making sure that appropriate intervention is actually done?
You mean the patient's data is being submitted into the system, but nobody's looking at it?
Yes.
Yeah. So it's a big open question so far. It's sort of one of the things that that is a legitimate thing to be worried about as a clinician. Again, I think having written protocols for how you adhere to patient monitoring, and two, making it clear to the patient that this is not emergency care, that this is just chronic care monitoring, and if at some point there's a problem, you need to pick up the phone and call us. A lot of the devices now are constantly streaming data, right? So for an example is a respiration device that sits on the patient at all times. So at any moment, the patient could have a problem, and unless there's a system to alert of some catastrophic thing, that physician's going to miss it, but that doesn't necessarily mean that physician has violated the standard of care. So one would be carefully selecting the patients you're going to remotely monitor. Two, maybe having a red alert for patients who have a certain set of criteria that indicate that they need to be in the hospital or something like that. And three, getting a good patient consent to say, this is for monitoring purposes, for research purposes. This is not to pick up an emergency. If there's an emergency, we expect you or a loved one to get you into our facility. But we'll see. Maybe next year I'll come back and I'll have a case that sort of explains this for you, but I don't have one yet. Yeah, go ahead. Oh, hey, how you doing? Good. How are you? Good.
So there are a lot of companies out there today that provide kind of turnkey package for remote patient monitoring that interface to an EMR.
Mm-hmm.
For somebody that's trying to scale this to thousands of patients, is it less expensive to go that route or build it on your own?
Okay, Yeah, so so I am not an ops person, I'm just the lowly lawyer. But the question is does it make more financial sense to use an off-the-shelf, sort of fully formed package to remotely monitor very large patient populations, or does it make sense, or does it make more sense for a hospital system to sort of build it in-house? I don't know the answer to that. I could guess what you would say.
Well, I have sort of a biased view on that.
Yeah, I can guess what you'd say.
What I would say is that it is not less expensive, and the long-term view of creating, enhancing, and maintaining your own secure software platform is my view is that health systems are not software companies, that where a healthcare system, if it wants to be fully engaged with its vendor, can really help is by getting the clinicians involved and really thinking through the back-end integration with the EMR. But I actually do believe that, but I'm also paid to believe that. So.
There's no requirement. You can remotely patient monitor anyone. Okay.
All right,
thank you,
Yep.
everyone.